So welcome to the next episode of Endoscopy Essentials. This time it's a partner episode with our main sponsor Olympus. And we are going to talk about something quite exciting and new. It's a new ultrasound machine for EUS, and a very warm welcome to Khanh Do-Cong Pham from Bergen, Norway. Pham, you were among the first to use this machine, so we are very much looking forward to you explaining the new features, and maybe because we have talked a little bit before that, there's something I like very much, because what I observe is that the detailed imaging of EUS has become less relevant. So if something is dark, people stick a needle into it. If something is black, they put a stent into it. And I think there could be much more to EUS, and we have lost a little bit of ground, right? So please explain us what the new Canon machine, that's the new machine Olympus is working for. I think it's called Applio. What are the options, and in which way you have used some of them in EUS?
Thank you, Thomas, for inviting me. It's a big honor for me to be here. But I had the opportunity to use the Applio for 3 months before it was launched to identify some special features which could be useful. And one of the features which I really appreciate, it's called superb microvascular imaging, or SMI, and that is a method to visualize low velocity microvascular flow in
beyond Doppler.
Yes, beyond Doppler, because it is extremely sensitive, so it is somewhere between a Doppler and contrast. And
shall we call it super Doppler?
Yeah, you can say it. It is it's with the SMI this is a Canon technology. It reduced the artifact and noise, and you have very high frame rate. So it gives you a very nice real-time microvascular flow in the tissue. And I have tried this technology in many situations, and I see it's very useful for several type of indication. And I use it to evaluate tumors, and also I found it to be very helpful to when I do FNA, FNBs. Sometimes you don't recognize where the needle is, or you don't see the needle tip.
Especially in the depth.
Yes, yes. So I have some cases, and I presented already this during the ESG days last year. But I will show you a clinical case.
Okay, so we start with that clinical case, a large ampullary adenoma.
Yeah, so this was a large ampullary adenoma scheduled for resection. So here we see the endoscopic view, and so before we decided if we could resect, we did EUS to see if there's any kind of invasion into the ductal system. And here is the one of the first B mode picture with the Applio, and I must say I appreciate a lot of details here. This is
details and infiltration depth.
Yes, yes,
both.
Here it's not so clear with the infiltration depth because it's only 3.5 centimeter, but the detail is quite good. And with EUS, we could not see that there's any infiltration into the biliary and pancreatic duct, and most of the tumor is just floating extraluminally. But here I show you the standard Doppler, how it looks like with standard Doppler. This is what you could expect it.
A few vessels outside of the tumor.
Yeah, yeah. Here's the SMI. So with the SMI, you can see the microvascular structures inside this tumor, and then you can identify the main feeding vessels to this tumor, and you can
It's not so micro after all, right? It's
No,
a
no, when you-
millimeter or two,
no.
or
It looks more scary when you
Yes.
put this, because you recognize this is going to be messy, because it's much more evident that here there are some major vessels feeding this tumor.
which we have seen on Doppler
Yeah,
before, but
yeah.
now the internal network.
Yes.
Ah.
Yes. And with the SMI, you can also reconstruct 3D. So what you do is that you scan with EUS the probe, and then the machine can reconstruct this, and that is what you see here.
Do you have to do standardized movements, like
Yeah.
not too many movements at the same time?
Yeah, you cannot move back and forth. You have to stand on one place, and then you scan.
Rotate.
You have to
Yeah.
rotate.
But keeping the instrument still, the tip.
Still, yes.
So if you deflect the tip, does it?
No, you just keep it in the
Straight.
same position,
Or
and then
same
you scan.
yeah. Okay. Ah.
It's with SMI, because they're so small vessels. It requires that you have a good timing. Let's say if the patient has to keep hold the breath, or you time that the exactly the moment, but it goes so fast that you can scan very quickly, half a second even, and then you press on the freeze button, and then the machine already stored all the pictures along all the way, and then you can use that tiny frame to reconstruct this. So if you imagine that the structure I showed you, the vessels are so tiny that if you have small movement, it will give you a lot of artifacts. So with this,
Or will make the vessel bigger.
yeah, yes.
Okay,
So
I
with
see.
yeah,
So this is not the biliary tree, right? So
No,
this
no.
is
This
the
is the,
vascular
yeah,
architecture
of
of
the
this.
the-
But that looks frightening.
yeah. So when you look at this, you know that it's a one major vessel, and you probably cut it off when you do the resection. But this gives you an idea that maybe you should be prepared. I had another case where you could see two major vessels coming into the tumor, and then you really definitely have to be prepared that it could bleed.
You ask
much
your
more.
assistant to have the forceps right at
Yes.
hand.
Yeah.
Okay.
And when we resected this adenoma, as expected, there was a bleeding, but then we knew that in this case was one major vessel, and then we just need to concentrate on that one. And we also used the RDI function, and could stop the bleeding. But then since we knew before the resection that it was only one major vessel, then you can be relaxed after that.
When the one bleeding is stopped.
Yes, yes.
That's interesting. Do you have experience with more ampullary tumors? Or
Yes.
Do they look similar? Do they all have vessels, or some
yeah,
more, some less?
they have all vessels, but in a small and also they can come in different sizes. But I had a case where we saw two major vessels coming in, and then I told to the referring doctors or the surgeons that this is going to be a bleeder. So if it's a two vessel, I'm not sure I can handle that because it could be very massive bleeding. So we were much more prepared. So I find that the function, the SMI function, is quite useful. This is an example of that.
So we have the SMI and the 3D reconstruction. The 3D reconstruction, can you reconstruct anything, or is it just the vasculature you reconstruct?
Yeah, for the 3D SMI, that could be useful. For example, if you have neuroendocrine tumors, you could in fact reconstruct the basket sign. So let's say you don't use contrast, but you still suspect it's a neuroendocrine tumor. But to visualize the basket network around the tumor, you can use this technique. It looks quite good, in fact.
So that means you can forget your contrast, at least for some
Yeah,
indications.
I think you can save a lot of contrast. It doesn't replace contrast, but you get a pretty good idea.
Okay, so maybe it's a step in between Doppler and contrast,
Yes,
which
I think
takes
so,
away
yes.
a little bit of
Yeah,
the
yeah,
contrast necessity.
Yes,
Ah,
I think you
interesting.
can, because it's quite easy to activate this function. It's only one button, and then you can see is it really worth to use the contrast or not. But it doesn't replace. It gives you a lot of information.
Okay, now we are very curious. I think you have to show us more.
Yeah, so I show another way I have used the SMI function. The SMI function is a digital method. You can choose the color. You can define the color, and in this case you see that this is a different grading of the color, because what the machine is able to do is to give you like a 3D structure of the 2D picture of the vessel. But I show you here a picture where we puncture with a FNA needle, and because of you can see the vessels, we can avoid them, and potentially it could give you perhaps better,
if possible, have a track between the two, or between the slightly larger vessels. Huh?
Yes, and here you can see this kind of vessel we were not able to see with Doppler, and we could avoid them with this SMI technology.
Probably, of course, we have to get used to it. Huh?
Yes,
so
yes.
we have to use it during the FNAs and see.
In fact, when I with this function, I use it more than Doppler. I prefer this than Doppler.
Well, Doppler I found is often a bit boring. You see the large vessels, but
Yeah,
it
yeah,
doesn't
yeah.
tell you much about the
No,
internal
no.
structure.
No,
Yeah. Okay.
And for FNA, I think it's much more useful, because you want to avoid also the tiny vessels, because if you see the tiny vessel, then you see also the larger vessel. Here I show you a pseudocyst. This is the just to give you an idea what here's the standard Doppler, and then the power Doppler, and then you can see the wall of the pseudocyst with the tiny vessels. This you cannot detect them with a normal standard Doppler, but it's a little bit scary sometimes to see that there's so many vessels in the wall which you don't see.
But if you can't avoid them, maybe SMI vessels are less bad than Doppler vessels.
Yeah,
because they're smaller.
Yeah. They just sometimes you just puncture and pray, and then it still works. But I tried to reconstruct the vessels in a larger structure like a pseudocyst. But the larger the structure, you can only scan what is in the scanning size of the EUS. It's a physical limitation. So larger structure like this, for example,
bigger
pseudocyst,
pseudocyst.
yeah, it will not work that well. But still, you get an idea that okay, there are some vessels surrounding this pseudocyst. But one of the most useful features with this SMI, I think, is during FNA, FNBs. And here you see an adenocarcinoma, and you don't see the needle inside so evidently. You see that maybe it's a tip there, but when you put on an SMI, you see that the movement, because it's recognized micro movements, you can see much easier the movement of your needle.
So you pull the needle back and see it.
Yeah,
much easier,
yes,
more easier than on the left side.
Yeah, and if you, let's say, it could be a guide wire or it could be a needle, but you just need a tiny movement, just like a jiggle with a device, and then you can recognize where you are. You don't need to pull it all the way. But during puncturing, I find it important to recognize where the tip is, and it's not always easy to find the tip. But here I just need to have you just kick the needle a little bit, and then you can see the vibration, and this vibration comes, it's recognized very easily with the SMI.
Yeah, that's a very convincing example.
and especially when you go to in the depth. Let's say you have a larger mass, and then you see the scale is 4 centimeter depth in adenocarcinoma. It is quite often that it's hard to find the needle.
Whether it's too far or not.
Yeah.
Good point. So also the people not interested in sophisticated imaging will like it because it helps them puncturing.
Yeah. It's like everyday useful.
And otherwise, I think what kind of clinical information we are going to get of the SMI in tumor diagnosis, we probably don't fully know yet.
No, this is in fact, this technology is known for external ultrasound, but we got it now available in US, and what are the potential? I don't know yet. I had tried on the Applio for 3 months, and this is what I recognize with the SMI. And SMI, I think, should be a standard function for EUS in the future, because it's so useful, it's so simple to use.
And also closing the gap, which I've always painfully felt between EUS and conventional ultrasound, because there are so many features on conventional ultrasound.
Yes.
Which are useful there, but we underutilize them. So this is one big step forward, I think, into that direction.
I think it's very exciting that Olympus and Canon has this collaboration, because Canon is a major player in radiology, and they have the CT scan, MRI, and high-tech ultrasound, and Olympus is a major player within endoscopy. But this combination, it opened up for new possibilities. So what we have not had before in the US, we can get it from technology from Canon, like for example SMI.
Yeah, good. So I think that's convincing. Everybody is looking forward how to use it, whether it's useful in esophageal cancer, which we abandoned surely in pancreatic cancer, neuroendocrine tumors for sure, differential diagnosis. So we have to learn a lot in the years to come. So Pham, how would you summarize this preliminary experience with superb microvascular imaging, SMI?
Yeah, I think SMI is very easy to use. It's only one button you need to press, and it gives you access certainly to vascular details which you have never seen before. And I showed you that it helps to guide you the biopsy needle, and potentially also increase your yield perhaps, and avoid bleeding. But I also showed that you can use it for pre-resection assessment, and perhaps in the future as a guide for therapy. And in some cases, we see that you can also reduce the need of contrast. And when you use a SMI, you can have it in a single or dual screen. When you have a dual screen, you can see the standard B mode, and then you can compare with the SMI to give you more information. And also I showed that it was possible to perform 3D reconstruction of a microvascular system with this function.
So let's talk a little bit more about 3D. One thing we learned is that you can 3D reconstruct smaller structures like that ampullary adenomas. When it comes to very big areas like huge pseudocysts, it's less precise.
Yes.
But you have more examples.
Yeah. So 3D is the new feature which is unique for now for within the Applio, and this is the first reconstruction of the biliary and pancreatic duct from the papilla.
Oh, it's ultrasound, not
Yes,
MRI.
this
it
is
looks like MRCP a little bit.
But this is the first case.
Yeah.
I spent some time to understand how it worked, but you need to stay in one position, and then you scan by rotation. And this the machine gives you a lot of noises, but everything which is fluid filled can be used as a contrast. So we define everything fluid filled and give it a solid color. Otherwise, it would be black. Right? So revert the picture, then it become clearer. And then we could remove the noises, and then you can see the more detail of the ductal system. But this theoretically, the detail of this picture should be better than MRCP, because the resolution is much better.
So it's a close focus. You probably can't see the entirety of the CBD.
Because you have to cover it can only cover what is the field of view of EUS.
On one EUS image,
Yes.
which you then slightly move.
Yes.
But as you said, you can't pull back.
No, you cannot. There's a function for that, but it unfortunately doesn't work so well with the linear echoendoscope. But it gives you like a tubular 3D picture, which is very difficult to interpret.
Okay, so our next training is 3D imaging of the periampullary ductal area.
Yeah, I think, for example, with this 3D reconstruction of the duct, it is quite easy to do, and it gives you a better understanding of the anatomy. And I think let's say you can I think if in cases of IPMN you could use this technology and give you a better picture.
Maybe, but we don't know. Also pre-ERCP, if you do this for CBD stones, then you know where the ducts are running, which is maybe not helpful, but never bad.
Yeah. I think one of the ideas I have with this technology is that if I do a 3D scanning, and then because one of the weakness of this technology still is that we don't have any reference, because it depends how fast and the 3D angle in relation of the ducts is not might not be exact. So what we still need to do is to, let's say, you match you can compare to the MRCP and CT pictures to see how fast you need to scan to get a standardized angle. But if you manage to do that and it becomes standardized, I think that information will be extremely useful for example, performing ERCP, because you can match this angle and you recognize some of the fixed standard anatomical structure, like the shape of the duodenum in the spine, and then you can use this information from EUS, and then we give you an idea what angle you should put your cannula.
Aim at.
Yes.
That's interesting.
Yeah.
More 3D examples.
Yeah. So at the beginning I had to understand how the machine works, how does it scan and reconstruct the 3D. But in fact, it's a triangular sector, which is reconstructed to a cube. And then when you scan, you get in fact three pictures, and then it can reconstruct to a 3D. Here's an example of a cyst. What I have done here is to define everything which is liquid to be transparent, and what is touching the liquid, like the wall, will become solid, and then you can create a virtual cystoscopy. And here's an example of a 2 centimeter large pancreatic cyst, where you can see the detailed structure and part of the different cavity, inside the cyst. This is quite unique, and you can also go inside the cyst and do like a virtual looking around inside the cyst. Instead, but just imagine, instead of just looking at the cyst like we have done so far, but you can in fact slice the cyst and look inside.
Well, the virtual endoscopy reconstruction is fascinating. You were mentioning it could be for the ducts as well, maybe one day.
I think with this technology, you could scan. Let's say if you have a cyst which is connected to the main pancreatic duct, for example, it will reveal that, and theoretically you can go in and go along the duct in and see how they connect. I think since ultrasound EUS has so high resolution compared to other radiological modalities, then the imaging of especially the pancreatic cyst in 3D will be extremely clear and also maybe useful for clinical decision.
It's really, really interesting. I think when we spoke before these podcasts, you said there are more technologies in the ultrasound machine, but you also had a caveat that they have to be explored, because the EUS field might be different from the transabdominal or other fields, right?
Yes.
So step by step, we have to work ourselves into those new areas.
Yes, I think there are, as I said, it has to be released little by little from the company side to us. I think for some people who are curious and to see if it's any potential, because it's what I have shown with for example, 3D reconstruction is it is the same technology which has been used for fetal examination when you have a
which is extremely far developed.
Yeah. So we just take the same technology and put it into EUS and put in a smaller ultrasound probe. But there are several interesting features from other specialities, and one of the features which I hope one day could come into GI world is, for example, the fly-through, and that's it's already several years old technology from Canon, but I think you can scan any ductal structures which is fluid filled, and then you can go inside and do a virtual ductoscopy.
That sounds fascinating.
Yeah.
Well, at the end of this, maybe you told me you have another vision, and you also already mentioned it, when we were looking at the distal duct, that's image fusion.
Yes, I think it has to come, because EUS is, I think it's quite difficult to recognize 2D pictures. But most of the things we do with EUS now is very related to HPB. And in all the HPB cases, you have either CT scan or MRI. And why not use those information and combine with what we have? Because EUS gives you the resolution, while the other modalities give you the 3D anatomical understanding.
The broader picture.
Broader picture. Yeah. And I think one day I hope that we can see a fusion of these two pictures, so that, let's say, we can give a scenario. One of the more difficult problem for me is when I need to scan the men's syndromes. Let's say you have a lot of tumors in the pancreas. You can see on the CT scan that there are several tumors, but when you start to scan with EUS,
which is which?
Yeah, which is which? Yes, and which one are you scanning the same? And we have no way to know exactly. And I think that a lot of highly specialized EUS practitioners miss that. And we can make mistakes. So I don't dare to say that I am correct when I count. But if we have combined it with the CT, you get that much more. That you'll be more confident to say, okay, that was we have seen that tumor in the head, and now we scan from the stomach, and it's not it is that tumor, you know. So we don't mix.
So to combine the overview with a focused view.
Yes, and in order to do that, you need a collaboration with companies which has all this technology in-house, and I think that this collaboration with Canon Olympus is so a good match, and that they need to use the potential and bring us more technology we can reuse for our patients.
Well, we clearly understand the plea to move this forward and not get stuck at a certain point. And so at the end of this podcast, I can only thank you very much. It was a fascinating journey. I like this Back to the Future. Imaging is more relevant than you think. And you showed us quite some example where it could have therapeutic implications. So watch it. And thank you very much.
Thank you, Thomas.